Thanks, Georgina and Helen, and thanks for inviting me today. So my name's Louise Brady. I'm the National Primary Care Nursing Lead at NHS England. I've been in post just coming up to 12 months, and I'm also still a practicing general practice nurse in my local surgery in North Yorkshire. Next slide, please. So I've been involved with experience-led care, Georgina and the team, as far back as 2014. That's when I started getting involved in undertaking group clinics. And at the time, there was a national group made up of allied healthcare professionals across England that looked at the evidence base. So that's a paper that I got involved in writing with a pharmacist and a consultant rheumatologist. And it just, again, reminds system leaders when you're talking about why group clinics are important, that we refer back to the evidence base. So this is really, really important for primary care, because it doesn't matter, as Georgina said, whether it's a long-term condition or whether it's a public health focus. We know that group clinics provide important touch points and impact across the life course, particularly for primary care. Next slide, please. So yeah, there's been a lot written, mainly by medics actually in the early days, because it was a model focused on the house of care, on chronic disease management. But I've put some links in there for you again, if you have to chat to your clinical directors or if you've got to go out and talk to other nurses. There is plenty of evidence to show that this creates excellent value at neighbourhood level. Patients love it, clinicians love it. You are creating capacity and continuity in the primary care nursing workforce in particular. And this is a workforce that is delivering 6 million one-to-one consultations each month. So as a general practice nurse, you know, that is huge. And we've got challenging issues with GPs and nurses in particular and others. So this is definitely something that we need to be thinking about. Next slide, please. So as I said, going back to 2014, Georgina and I worked with the regions in NHS England and with our directors of nursing, and we published, Health Education England published this in 2020, just sort of during the pandemic. So we were able to scope out and look at 700 GP practices in the north of England. And this was mainly a nurse-led project under the General Practice Nursing 10-point plan. And these are the key headlines, really. So we created capacity through efficiency gains, which Georgina's talked about. We had a particular focus on type 2 diabetes. So we knew that by using group clinics, we could reduce DNA rate by 75%. What we saw pre sort of primary care networks was improved integrated working with our primary and community colleagues, improved staff resilience and well-being. So we have nurses saying that they felt that morale was very low, and then as soon as they started to undertake group clinics, it shot up. It supported good culture and primary care cohesion, and it definitely increased the quality and outcome framework achievements per practice. So it's really, really important to share this evidence-based practice as well as the practice-based evidence. Next slide, please. So I started working with respiratory patients a long time ago, looking after patients with asthma, COPD, interstitial lung disease, and I believed it was important to meet with them in the community, you know, and that's something that we see as registered nurses all the time in general practice. I've been breathing all my life, nurse, but I'm just starting to feel it. So not everybody has that respiratory diagnostic in place. So it's about building trust and confidence with patients, carers and communities. Next slide, please. And there's a lot of work and evidence, both nationally and internationally, on health inequalities. And for me, as a registered nurse, reducing health inequalities starts with restoring relationships. And I think those of you who are expert in delivering, whether it's face-to-face or video group consultations, know that this is a model that works for and with patients. So if we start with the patient and work backwards, we can't really go wrong. So you'll see in this picture, I have sessions with respiratory patients, and to the right-hand side is a group of patients with learning disabilities. Next slide, please. I won't go through this a lot, but it's just to show around the research to do with social isolation. So another good evidence piece really is when people say, well, why should we do this at practice level? Why should we do this at PCN level? Well, we know if we've got a critical focus on respiratory, you know, that smoking increases levels of social isolation and loneliness, and we can't possibly tackle that with every smoker that's registered across our conurbation. So we need to be able to approach these kind of topics within a safe and effective environment. Next slide, please. And we know from a health and digital literacy perspective, this again is national and international evidence, that if we don't tackle low health literacy and we don't spend the time that patients tell us they need, we're going to get fewer healthy behaviours. We're going to get low levels of self-management and low response rates to public health campaigns. Next slide, please. Again, more evidence on reducing health inequalities and supporting better health and digital literacy. And this is an unintended consequence of using video group consultations and face-to-face consultations in a hybrid way. So we know that 42% of working age adults in England are unable to understand and make use of everyday health information. 61% of England's working age populations find those materials containing both text and figures too complex to understand. And 43% of working adults in England struggle to calculate a childhood paracetamol dose. And we haven't even added into that equation the complexities around English not being the first language for many patients, or cultural challenges. Next slide, please. So I'm going to tell you a quick story now. So part of my role as a clinical educator is to go and support newly qualified nurses. And I was asked by a practice manager to go into a PCN and work with this nurse around respiratory reviews. And what was happening was the patients were sending in the asthma control test, which is an evidence-based, evaluation, if you like, but it is subjective. So patients fill it in and tell us how they're feeling around their asthma or their COPD. So I rocked up at this practice this particular day, and I was expecting to see an afternoon clinic full of patients. And the nurse said to me, "Oh no, nobody's coming in." What I do is I look at the ACT scores, and then I ring each patient to see if that's actually a genuine reflection of the respiratory symptoms. And as she picked up the phone, say there were 10 patients in that particular clinic, over half of them were critically unwell. They didn't know how to use their inhaler. One lady needed to come in for an acute review with the GP. And so having these kind of experiences, you know, it isn't safe to do asthma reviews. Annual reviews by the telephone is not safe. And we had a long discussion at that particular PCN, and I took it to the national team at the Quality and Outcomes Framework. So you will see in the new GP contract that it talks about face-to-face respiratory reviews or video consultation. Telephone's not in there. Telephone's fine for a quick follow-up to check, you know, that medication is satisfactory, but it is not good enough for an annual review. And a lot of these patients that had filled in the ACT had put that they were okay, and when asked why they weren't okay by telephone, they didn't want to bother the doctor or the nurse. So although the asthma control test is an evidence-based tool that has been used frequently in general practice, we have to remember that this is subjective, that we're dealing with complexity, we're dealing with patients, and we need to be able to see patients, you know, because 95%, as we know, use their inhalers incorrectly. This is where group consultations come into their own. We have the worst asthma deaths in Europe. So again, we should not be undertaking annual reviews via the telephone. Next slide, please. So how do we build relational continuity within our primary care teams in this digital age? So in video group consultation, we can confidently do that. And we create a safety netting in remote consultations. We are able to see the patient's colour, we can observe soft skills, we can talk to them about their mood, their eye contact, we can ask them to go and get their inhaler. And we can actually see what's happening. So it is very, very important when we're under time pressure challenges in primary care. And creating that effective partnership of trust is absolutely key between clinician and patient. Next slide, please. So I think throughout this, we need to look at the health literacy umbrella. So what are the values and the preferences for our patients and carers, and how do we actually build that continuity within our group clinics? Next slide, please. So at NHS England, we worked with experience-led care during the pandemic and post-pandemic, and we offered and we commissioned training on video group consultations. So some of you on this call might have been part of those original Sentinel sites. Next slide, please. And what's really important within the asthma is to capture that qualitative data as much as the biometrics that Georgina talked about, because it's those things that matter to patients, and it's those things that really makes a difference to quality of life. So with that particular group that I worked with, these are the kind of things that the patients were saying. You know, they wanted to be able to do the things that we all take for granted. You know, being able to go swimming, not being breathless, washing your hair. These things, you know, are not quaffable, but nevertheless, they're really, really significant. Next slide, please. And you've probably all seen this slide before, which is from Georgina's team. But again, when you're talking to your colleagues or your community colleagues or your commissioners about the value of face-to-face and video group consultations, it's about people and families. It's about continuity of care. And for clinicians, it's about creating a workforce that can thrive, because we're very, very challenged at the moment across our systems. Next slide, please. And that's me. Thank you very, very much for listening. Happy to take any questions in the chat.
We'll take some questions at the Q&A bit, Louise, as well. But anyone who has got questions, do pop them into the chat now, and we'll move forward and hear from two teams. So Holly's going to speak first on behalf of the Burlington team, and I know she's got loads of backup with her today. So Holly, over to you.
Thanks. So yeah, we started doing group consultations in the end of October. So we've been doing them about 5 months. And we're quite a large practice. We've got about 18,000 patients, just under. And we decided to start with asthma because we've got just over 1,000 asthmatics. And when the inhaler switches came under IIF, we knew that we wouldn't be able to switch everyone. We just haven't got the capacity to do individual face-to-face appointments with the entire group of asthmatics. So we started doing group consults. We do a mixture of face-to-face and video. We do the face-to-face ones, we hire a local church hall and do them there. And we provide refreshments. And those groups, we started quite small, and the last one we did, I think we had 19 booked in, so they have got bigger. The online ones, we offered a very early morning session, 7:30, and we offered a lunchtime session so that we'd try and cater for the people that work. And I think those time slots did work quite well, although the 7:30 one, our DNA rate was quite large. But I think since October, we've seen about 183 patients in the group consultations, and we have had really good patient feedback. I think we're still getting the balance right at the moment. Our DNA rate is very big, and we've got 2 or 3 facilitators trained. All our practice nurses are trained in it, so we've got 4 practice nurses. They originally started, 2 of them were doing face-to-face and 2 doing online, and they've now just switched so that Kevin, our practice nurse on here, was doing online, and this week, this week is his first face-to-face session. So our facilitators switch between the 2, so they're trained in both. And one of our facilitators is our coordinator for getting everyone invited and getting all their information from them and getting the ACT scores back and doing the results charts. Our results charts have the ACT score, the smoking status, and the number of blue inhalers that the patients have had in the last 12 months. Most people have been very happy with the group consult setup. I think you're never going to please everybody, and we have had some feedback that patients didn't like having their scores shown publicly in a group. But generally, the feedback has been a lot more positive than I thought it would be, actually. I thought we would struggle to get people invested in the group sessions, but we've had some comments from people who, particularly as we started doing it sort of coming out of COVID, that have felt they've said that they'd felt very isolated, and it was really nice to get back into a group setting. We've had some that have said that discussing their symptoms and their asthma triggers with other people, they've found really helpful, and they've got tips from some of the other patients about how to control their symptoms, their inhaler technique, their triggers, and that, I think that has been much more positive than I thought it would be. I did think that we would struggle with that. One of the hurdles we still have got to overcome, well, there are 2 main ones. One is the DNA rate, which we find very surprising because our coordinator phones and books all the patients in. Then she phones normally the day before and reminds them about their appointment, checks they've got the link, checks that we've got their ACT score and all their password and all their information to get on. But still, our DNA rate remains very high. They also get a text reminder as well that day. Whether people get cold feet about the group situation, I don't know. I mean, on Monday, I think did we have 6 booked in, Hayley? 5 or 6, and we only had 1 turn up. So in effect, she had a non-group consultation. But then the Friday before, when we'd got the 19 booked for face-to-face, I think we got maybe 13. I think that might be our highest number. I think that's what we had. So I think overall it has been very positive. Another thing that we do have to overcome is we have probably a quarter of our patients English isn't their first spoken language. So we are going to have to find a way to cater for them as well. At the moment, we've stuck with mostly our English patients. We have had some interpreters attend on video and face-to-face, I think, but we are going to have to come up with some sort of plan for the non-English speakers. Normally we would use an interpreter on the phone through our interpretation services. We do have a social prescriber that speaks a number of different languages, so we might have to involve her at some point. So I think
That's really brilliant,
Is
Holly.
that,
Can I just
think
ask
that was
you?
probably most things I was going to say. Yeah.
Yeah, I was just going to ask you on a couple of things.
Yeah.
With the English as a second language, do you
Yeah.
have a particular number, community who speak, quite a lot of people who speak, say, Romanian or a Southeast Asian language? What's the kind of what are the languages that are?
We've got a real, our practice is very, it's an area of real deprivation. We're one of the highest deprived in our area. We have a real mixture. We have a high Romanian, we have high Roma, we have Polish, we have Portuguese, we have Lithuanian. We have a real mixture. So we would need to find something that catered for all of those, because we can't
Yeah,
exclude somebody
so
just because of their language.
no, absolutely. So one of the things that people have looked at that does seem to work well, is if you can get a facilitator who speaks the language, and bear in mind that you could potentially have facilitators who are not necessarily employed by the practice. So it could be, for instance, if there's a Roma, kind of community liaison person, or if there's somebody who's sort of kind of community leader amongst your Portuguese people or whatever, potentially you can look at including them as part of your team to be your facilitator. And then you still need a translator, but the translator is just for the clinician, so that then sends a very different message to the patients. We're going to conduct this group session in your own language, and the clinician will have a translator. I've actually watched group clinics happening in different languages, and sometimes we forget that 7% of what we learn and understand comes from the words that we use. The rest of it comes from tone of voice and our non-verbal communication.
Yeah.
So you'd be surprised working, and it probably might be more of a face-to-face thing than an online one, but it's definitely worth, as part of your development plans, giving that a go. But particularly if you've got a social prescriber who might speak some of those languages, it'd be a great use of her as a resource, because she could also give them advice and sort of signposting and do a bit of social prescribing at the same time. So do think about that. And on the DNA rates, at least the good news is that the group clinic doesn't last as long when you've got us, when people DNA, but it's definitely worth over inviting people, and
well, that's
maybe
what we've started to do. We've increased our maximum for the online and the face-to-face to 20. I think 20 for both, because we know that they'll never all turn up. We've also, the invites that we're sending out, they can book their own appointments via a link, which I think will help uptake a bit, because they won't then have to sit on the phone waiting to get through to reception for ages. So I think that will help. But I think the only thing last week when they had the 13, Rachel was facilitating, and I think that was a bit much. But it's very difficult to get the balance between a very low number, because your clinic is, you're going to get the DNAs, and previously we were only booking up to 10. Then if you get a high DNA rate, you've only got sort of 2 or 3 people there. So it's getting the balance right. And the other thing that the nurses have struggled with is the admin side of it afterwards. But we're training up Hayley, one of our facilitators. She does the facilitating and the coordinating. The nurses are training her up to do the admin afterwards, so that it's not quite so much time out of the nurse's clinic. And if we do have a very well attended clinic, it doesn't put pressure on the nurses who, they have a gap in their clinic for the group consult, but then they jump straight back into their normal session. So it's still, we've only been doing it 5 months, so we are still trying to tweak different things and get the balance right.
The key is the continuous reflection and improvement, really, which is what you're doing. And the other thing is, make sure that when you have had seen somebody in a group clinic, you immediately book them in for their next review in a group clinic. So there's no reason why you can't have those group clinics scheduled, a year ahead, so that you can say, right, we'll book you in, for your next one. Do you know what I mean? So you're starting to sort of like also send a signal to people, this is the way we see you now. Do you know what I mean? So
yeah, we have, Hayley is very clear with them that this is how we're seeing patients now. It's not a choice of this or a telephone call. It's this is the way forward.
That's key.
Yeah,
absolutely key. Brilliant. So, well, I'm sure that people will have questions for you. So do pop the questions into the chat, people, and let's move on to you, Maggie, now. So if we just move the slides on.
Yeah. Okay. Good afternoon, everybody. I'm Maggie. I'm a practice nurse, and I also work with the Training Hub, which is my main role these days. I've been doing these video group consultations for a long time, particularly the video group side of things, for when COVID came with Georgina and Helen. So I can echo a lot of what the other ladies have said on this call, but I'll just take you back very quickly to my journey, in that slide there kind of summed it up, because when COVID hit, I honestly thought there was no role for me in primary care, because I thought to myself, there's no point. We all need to like jump on a train and get down to one of these Nightingale hospitals and get doing something useful. Was my immediate thought, and that stayed with me for quite a while, I'll be quite honest, thinking, I just don't know how I'm going to see any patients anymore. I don't know what my function's going to be. I'm not desperately keen on doing phone consultations in any way, shape or form. So that's where I thought I was actually going to end up. I actually remember even telling my family that I was going to go on the train and start working in secondary care. God only knows what I'd have done, but that's where I had in my mind, until obviously we kicked off with this new way of working, and that came very, very quickly after the start of COVID. I think we trained in April 2020, Georgina, or May, something like that. So we were right at the front of it, really. Okay, next slide, please. And I know some of you on here have never done this before, including my colleagues, Jess from Southport and Formby, who are also on this call, who I'm working with now to try and get this little project off the ground. But the digital way of things is not my way, I'll be honest. I've never in my life been digital at all. And that look on that baby's face mirrored the look on my teenage son's face when he shouted up the stairs to my husband, Dad, Mum's going digital. And it was a look of total horror and shock that I would even consider doing anything digital. I've been described as a digital trailblazer, which went down with much hilarity, as you can imagine, in a teenager, because I'm not that great at it, to be honest. But this is my story, that anybody can do this. It really, really is very, very doable. It's very easy. It really is, and it's a whole lot of fun. I'll tell you that much as we go on. You'll see. Next slide, please. So as I've said before, I've done all sorts of things in this way. I've done long COVID, diabetes, menopause, postnatal women, cancer care reviews, long COVID, the lot. And I started off with asthma, though, and I purely started off with asthma because I felt that was the easiest thing for me. So I'd recommend, if you're venturing into this, pick something that you're very, very familiar with and that isn't going to stress you out, because it's stressful enough trying to do something in a different way, let alone think I don't really got a big grapple on that subject. So for me, I was really confident with asthma, and I thought that way I'll get my head around doing the actual consultation this way without actually worrying about what I was talking about. And I just wanted to show you our sort of typical results board, and it has been said before that you can do the results board however you like, and that's very, very true. This is about the most formal results board or discussion board that I ever do. I usually make mine very, very graphic and very, very visual, so that people don't that they can home in on it, and they can see straight away what I'm trying to achieve. So I think some of this highlights what Louise was talking about before about the asthma control test. So you get your results board, and typically if I was just focusing on somebody's asthma control test, I'd probably look at John and go, oh, he's fine. I don't need to worry about John. But if you look at John, then you think, well, why, if John has got a score of 24, why has he had 3 exacerbations in the last 12 months? And why has he used 3 inhalers in the last 12 months? To me, those figures don't add up. Equally, you could go down and think, well, George has got an asthma control test of 8 and he's used 5 blue inhalers. God, there's something we need to do there. And the same for Ringo, and the same for them all. Even though you can't see anybody using that, straight away through your mind, you're creating a picture in your head, aren't you, about what you can see. And then when you come to the patient, then obviously my first question is, how did you interpret that asthma control test? How did you get to 24? And like Louise was saying, it's a very, very subjective test. So I think the results board helps to then create that conversation. And certainly amongst the people, so funny. I mean, patients would honestly crack you up, wouldn't they? So you'd say, well, why have you used so many inhalers in a year? But you say that you're really well controlled. And we've all heard this before, haven't we? Well, I've got 1 in my car, 1 in my handbag, 1 in my caravan, and somewhere one Johnny needs 1 for school, 1 for such a teacher, all of this sort of stuff. And this is the brilliant thing about a video group clinic, because when they start talking like this, you create the picture, don't you? And then somebody will chip in, like George will chip in. Oh yeah, I've got 2 in my car, blah, blah, blah. I collect 1 every month, Maggie, just in case, you know, it's always best to have them in, isn't it? And you know, they've probably got a great big stockpile in the kitchen. So it's perfect for that kind of thing. This sort of information that you would never, ever pick up on if you were either on the phone or sometimes if you were face to face, because sometimes they don't tell you the truth, do they? But when one person in this video group clinic starts telling their story about hiding the inhalers, they all pile in then, and then you just know it's quite an issue. So then you obviously need to say, well, listen, you know, we're looking at how many inhalers people are collecting. That to us means that you are maybe uncontrolled. So maybe don't pick 1 up every month, apart from the cost of the stuff. You don't need it. You know, you stop piling them. Are they all in date? All of this stuff. It just gives like a really rounded conversation of asthma and the way that why we're asking these questions, and the importance of only having 2 if you need them. But at the same time, if you need more, then that is going to flag up to us that you probably aren't as well controlled as you should be. And I always love the inhaler technique one, because the things I see never cease to amaze me on that one. And so when one of them says, oh, I'll show you how to take it. And actually, it's been said before that you can always whiz upstairs. You know, you can always, the good thing about this is, we'll go and get your inhaler then. No, you know, how many times do we see these people in surgery and they've not brought their inhalers? Tons. Right, go upstairs and get it. So there's no excuse, off they trot and bring it down. And then when you see the inhaler technique, you think, dear God, how have they managed all these years taking their inhaler like that? And then somebody else said, and this is a true story, said, oh God, I've been taking mine like that as well for years, Maggie. And you're like, I've seen you time and time again, face to face, and it's not the way you've told me. So when you actually see people and they show you on the screen how they're taking it, I think it is a massive, massive learning curve for all people on that call. And when you break it down into an informal, fun way, they don't feel judged in that sense. So they don't feel as though they've got to put a show on for you or anything. They usually feel quite comfortable showing the technique in that surrounding. And somebody's made a good point about the word exacerbation, because what I mean by the word exacerbation isn't what they mean. And so I often break that down to, I mean, a cough, a cold. I mean, when you're using your inhalers more often, I don't mean like a big mad admission to A&E necessarily. They know themselves when they have been bad or not. And they'll often say, if what I would call an exacerbation, they probably just say they felt a bit off for a couple of days. But we know, don't we? We're nurses. We know what an exacerbation is. And that's about the conversation that happens when you do a video group clinic. You can pick out all this information. Next slide, please. And I think this has been covered before. These are the benefits of consulting in this way. Easier for patients, an awfully lot easier for patients. No travel. learning from the peers as well as the practice nurse, because absolutely so much better than somebody else telling them about their inhaler technique or somebody else telling them not to stockpile blue inhalers than you telling them. We know that, you know, we've seen that so many times. And then as well as that, there is a time, again, for sure there is. We've all got very, very slick at this now. We know how to write the notes up as we're going along. We use our facilitator, maybe cut down on the time. So stuff like that, there's quick wins either way. And I have put at the bottom, it is fun. It is really, really fun. I've never laughed so much doing these kind of consulting in this kind of way. And to be honest with you, neither of the patients. I've had really, really good feedback. I can demonstrate feedback over the past 18 months from patients, and they've really learned a lot. They've loved it. They've loved consulting in this way. And I'm sure that we've made a difference to a lot of people through COVID and beyond. And I think that's me, Georgina.